Good. Good afternoon and welcome to you all. Thank you for inviting me to speak with you. As we start our discussion, I'd like to talk to you about some thoughts that I had as I prepared for today. Traditional cancer treatments for most types of cancer are chemotherapy, radiation therapy, and surgery. We know with a certain amount of clarity what effects those modalities can have on a patient's fertility. However, except for a surgery that affects reproductive structures, these modalities are not used to treat GIST tumors. Chemotherapy and radiation have proven to be ineffective against GIST, and only the rarely placed tumor will abut and therefore impact the reproductive structures. Today, the predominant treatments are oral targeted therapy and surgery. In terms of impact on fertility, there is a lot about the newer targeted therapies that we are just not sure of. For this reason, I found this talk challenging to prepare, and I can only assume that you must find that decisions on fertility preservation and family planning are difficult for you to make. Today, I will attempt to tell you what is known about the effect of GIST treatment on fertility and what is not currently known. In this way, I hope that our dialogue will increase your understanding and also help you to know what are important questions to ask. Let's begin. Today, fertility is important to cancer survivors. We know that many have not completed or even begun to build their families when they are diagnosed, and many find the thought that someday they may not be able to have the family they dreamed about to be an anxiety-producing and depressing possibility. Today we are going to talk about the risks to fertility posed by treatment, describe fertility preservation options, discuss implications for pregnancy, and list alternative family building options. First, let's talk about males. As I mentioned, surgery would only place a risk to fertility if it was adjacent to or impacted male reproductive anatomy. This is rare. In regards to the oral targeted therapies, several of which are mentioned here, the risk is unknown. At this point, no studies have been done on humans that demonstrate a decrease in fertility for men who have taken these agents. Based on animal studies, however, there could possibly be an impact on sperm production. If a decline in fertility occurs, it's impossible to know the timing or amount of recovery for any one given individual. Sperm banking is the recommended fertility preservation option for men who are concerned about this possible risk. It is performed at a sperm bank, and we recommend providing 3 collections that are spaced 2 to 5 days apart, with 2 to 5 days of abstinence prior to the first collection. At the sperm bank, men will masturbate until they ejaculate, then the collection is analyzed, placed in small vials, and frozen. Sperm that is frozen this way can be stored indefinitely. The cost ranges from $200 to $1,200, with the lower end of this range reflecting discounted rates that are available through the Livestrong Foundation. This fee includes 3 collections, the analysis, and first year of storage. Annual storage after the first year is approximately $450 per year. Since we are unsure of the effects that the targeted therapies can have on sperm production, ideally banking would occur before treatment begins. Collecting 3 specimens spaced a few days apart can take 1 to 2 weeks, so any patient who is interested should speak to their oncologist to make sure this delay does not present a risk to them. Some patients, however, may already be on treatment, with a projected duration of treatment unknown. If these men have concerns and would like to bank sperm, they should speak to their doctor about the possibility of taking a break. What about attempting pregnancy while men are on treatment? To date, we have no evidence that these drugs cause genetic mutations to the sperm. At the same time, there are no recommendations from the manufacturers that it is safe for a man on treatment to attempt pregnancy. Case reports exist of men who conceived a child on treatment, resulting in a healthy pregnancy, spontaneous abortion, and congenital abnormalities. These are case reports, however, and no studies have been conducted. For these reasons, it is recommended that men use a condom or their female partner use effective birth control while having penetrative sex. The duration of time that they should wait until attempting to conceive after the completion of treatment depends on the agent. Your doctor can advise you on that. Now let's discuss issues for females. Like men, surgery poses no risk unless it is adjacent to female reproductive structures. This too is rare. And just as for men, we do not know the risk that these oral targeted therapies can pose to a woman's fertility. As a quick review, the drawing on the left shows the female reproductive anatomy. It shows the ovaries, the fallopian tubes, the uterus, and a lining of the uterus, which is called the endometrium. The drawing on the right is a cross-section of the outer layer of the ovary, or the ovarian cortex. This is where a woman's eggs are stored. Each egg is inside a sac called a follicle, which you can see the arrow is pointing to. The eggs at the top are in a type of sleeping or resting state. What happens each month is that a group of eggs begins to grow. In the course of the month, these eggs begin to mature, and the follicles around each enlarges. Eventually, one of these eggs becomes what is called the dominant egg, and it is given off by the ovary to travel down the fallopian tube. If it were to become fertilized that month, it could create an embryo and become implanted in the endometrium. That is a pregnancy. All the other eggs in the group that started to grow that month would die off naturally. The number of eggs that a woman has at any given time in her life is called her ovarian reserve. A woman is born with all the eggs that we're ever going to have. A baby girl is born with about 1 million eggs, and as we age, we lose eggs each month by the natural attrition that I just described to you. Optimum fertility is in the 20s, with some decline in the 30s and 40s, and by the time a woman reaches menopause, which on average in the United States is age 51, we have about 1,000 eggs. So what are the potential effects that treatment can pose to a woman's fertility? Just as is the case for men, no studies have been done on humans. Based on animal studies, however, there may be an effect on women that can lead to a decrease in the ovarian reserve. Similar to men, there is no way for us to know the effects for any given individual. We do know, however, that many women can have additional risks posed by other factors, such as family history, obesity, smoking, and already existing infertility. One other factor for women to consider relates to the age at which she begins and the duration of her prescribed treatment. If you look at the graph, we know that women lose eggs naturally each month, resulting in a decline in ovarian reserve. If the ability to stop or take a break in treatment is unlikely to occur for several years, a woman can anticipate having fewer eggs at the point that she is ready to start building a family. This can potentially make it more difficult to conceive and may be a reason to consider fertility preservation. The standard fertility preservation treatment for women is egg or embryo freezing. This is performed by a reproductive endocrinologist and takes approximately 2 weeks to complete. Ideally, egg freezing should be accomplished before treatment has begun. It requires the patient to take an injection with a small, thin needle every evening for about 10 days. The picture on the left shows you the goal of stimulation is to support all the eggs in the group that have started to grow that month, so that not just one becomes dominant, but all the follicles in the group will enlarge, all the eggs inside will mature, and the doctor will be able to retrieve them for possible use in the future. Every other day during the 10-day period that she takes the shot, the patients will go back to the reproductive endocrinologist so that she can be monitored with blood work and transvaginal ultrasounds. They want to retrieve the eggs at the appropriate time so as not to over or understimulate the patient. On the day of the retrieval, as shown by the middle picture, the patient will go back to the reproductive endocrinologist's office where she will have an IV started in her arm and be put into a very, very deep sleep. Under anesthesia, so she has no pain, the doctor visualizes the ovaries with the transvaginal ultrasound, and using a very long, thin needle, he punctures the follicle and aspirates the content where the egg is located. He retrieves all the eggs in the ovary on one side, then the other side, and the whole process takes about 15 minutes. From there, the patient goes to a recovery room. Most women are awake and ready to go home in about an hour. The picture on the right shows you that the eggs are analyzed in the lab and fertilized with sperm to be frozen as embryos or frozen as eggs. The cost for these procedures can range from $10,000 to $18,000 to freeze embryos and $7,000 to $15,000 to freeze eggs. The range in this estimate reflects the discounted rates that are available at some centers through the Livestrong Foundation or Walmart's Heartbeat program for patients who have a diagnosis of cancer. What is the timing of egg or embryo freezing in relation to your treatment? Ideally, it will be completed before you begin, but be sure to talk to your doctor about the safety of delaying based upon your particular situation. If you have already started treatment and want to consider egg freezing, again, you should speak to your doctor about the safety of an interruption in treatment. Remember, as we get older, we have fewer eggs, so the success rate declines with age. Now let's discuss some issues related to pregnancy and your treatment. Oral targeted therapy can cause abnormalities during the development of the fetus that can result in birth defects, so women cannot become pregnant while on treatment. You may have to wait a period of time to attempt pregnancy either naturally or using your frozen eggs or embryos so that there is no danger to a developing fetus. The amount of time that it takes for therapies to clear from your body can vary, so you should speak to your doctor about the length of time that is right for you. We just spoke about pregnancy and related safety considerations for the baby while you're on treatment. There are other safety issues, however, that relate to whether or not attempting pregnancy is safe for you. If you become pregnant, for instance, will you be able to be monitored with the type and frequency of scans that are best for you? If you have completed treatment, how long does your doctor feel you need to wait until it is safe to attempt pregnancy? If you are still taking targeted medications, is it safe for you to interrupt treatment long enough to conceive and carry a pregnancy? There is one thing to consider if you hope to become pregnant in the future and will need to take a break. Using frozen embryos could potentially decrease the amount of time that you would be off treatment as compared to attempting natural conception. Of course, there is no way for anyone to be sure of this for themselves in the future, but it is one consideration when making fertility preservation decisions. At the time you want to attempt pregnancy using frozen embryos, they are thawed and the endometrium is monitored to make sure that it is optimal for implantation. Embryo transfer is a simple procedure that is done in the reproductive endocrinologist's office, where the embryo is placed into the patient's uterus using a long, thin, flexible catheter, much like a very thin straw. There is no pain, and the patient is awake throughout. She will return in about a week for a blood work pregnancy test, and about a week after that for an ultrasound to see if the embryo has implanted. Once pregnancy is confirmed, she will be under the care of an obstetrician for the remainder of the pregnancy. A pregnancy implication for males includes the concern that the drug can be eliminated in the semen and potentially be absorbed through the vaginal mucous membranes into the fetal circulation. Patients who are taking targeted therapies while their partner is pregnant are advised to wear a condom while having sex that involves vaginal penetration. Finally, I would like to talk about alternative ways to build a family for those who cannot or choose not to use their own eggs or sperm to achieve pregnancy. Third-party reproduction involves the use of donor sperm, donor eggs, or donor embryos. In each of these situations, the partner who uses the donation will not be genetically related. They will, however, experience pregnancy and childbirth. Donor sperm involves using sperm from another man to impregnate your female partner. You can select a donor based on various characteristics and traits that are on the Sperm Bank website. Some people have friends or relatives who are willing to donate sperm. This can work for some, but it is important that expectations are clearly spelled out for all to understand and legally accept. In addition, the donor should have medical and psychological screening done. Once a donor is selected, the female partner will see a reproductive endocrinologist. Intrauterine insemination is the most commonly used method for using donor sperm to achieve pregnancy. It is planned around the time of ovulation and involves placing the sperm into the uterus using a long, thin catheter. It takes most women 3 to 6 attempts before they are successful. Donor sperm costs approximately $600 to $900 per vial, and one vial is used per attempt. Eggs are usually donated by young women who want to help other women build their families. Your fertility center may have an egg donor program or can recommend an egg donor agency. As an alternative, you may have a relative or friend who is willing to donate eggs for you. Just as with donor sperm, it's important that you speak to a lawyer who can make sure that you and the donor understand all that's involved. The donor should have psychological and medical screening as well. Once you choose a donor, her eggs will be fertilized with sperm. Some of the fertilized eggs will start to divide and form embryos. After 3 to 5 days, one or more embryos will be transferred to your uterus. The remaining embryos can be frozen and stored for future use. The cost for obtaining donor eggs is generally about $35,000, including medical expenses and compensation of the donor. Embryos are usually donated by couples who have gone through fertility treatment and have unused frozen embryos. They are obtained from an embryo donation agency. One or more embryos will be thawed and transferred to your uterus using a very thin catheter passed through your vagina and cervix. The cost of donor embryos is less than that of donor eggs. Some women who need to be on continuous treatment will not be able to safely carry a pregnancy. If this is the case, gestational surrogacy is an option where you have another woman carry a pregnancy for you. Embryos that you froze before treatment, fresh embryos created with your own eggs, or donor embryos are transferred into the carrier's uterus. The carrier will have no genetic relationship to the child. Laws related to surrogacy vary from state to state, and because they are very complex, we recommend that you talk with a reproductive lawyer before starting this process. Once you have found a possible surrogate, he or she should be carefully screened to make sure that she is medically and emotionally healthy. Then you will need to finalize the financial and legal arrangements. The cost of surrogacy can be $80,000 to $120,000, including the agency and legal fees, medical expenses, and compensation for the carrier. In some cases, you may have a relative or a friend who is willing to carry a pregnancy for you without being paid. This is a good option for some people and would be considerably less expensive. However, even with the best of intentions, there can be problems if expectations are not clearly defined. Along with psychological and medical screenings, it's important to talk with a lawyer to make sure that you and your surrogate understand all that's involved and have a legal arrangement. A reproductive endocrinologist will plan the timing of your embryo transfer to the surrogate. Throughout the pregnancy, you and your surrogate will communicate as you have both agreed. You may even be allowed to be present at the birth. Adoption is another means of building your family after cancer treatment. Having a history of cancer does not prevent you from being able to adopt. In fact, some states do not allow agencies to discriminate against prospective patients based on a history of cancer. You will likely need a note from your doctor that includes your diagnosis and treatment, affirms that you are healthy or stable, and that there is no medical reason you could not parent a child. In addition, they may require a statement to the effect that your doctor expects you to be alive long enough to raise the child. Adoptions can be domestic, where the child is born in the United States, or international, where the child is born and lives outside of the United States. International adoptions are currently very restrictive. Some countries do not allow people who have been treated for cancer to adopt. Adoptions can be arranged through an agency or with the help of a lawyer. Before you can adopt, a social worker will do a home study to assess your ability to care for a child. The social worker will ask you things that may seem very personal. This is to make sure you understand what is involved and are ready to proceed with adoption. The social worker will also do a medical assessment and tell you exactly what you need from your doctor. The cost of adopting a newborn child in the United States is generally around $40,000 and can take as long as 2 years. Many factors enter into decision about fertility preservation. How important is it for you to have a biologic child? How likely are you to be successful? How comfortable are you with assisted reproductive technology? Do you have concerns about safety or religious or cultural beliefs that prevent you from using assisted reproductive technology? Some patients are so stressed at the time of diagnosis they just want to begin treatment and will think about family building later. Finally, what and financial support do you have? There are probably no more personal decisions that someone will make than those around building a family. These decisions can be complicated by the information that we have and don't have related to the treatments for GIST. It is essential that you consult with your oncologist as you consider attempting pregnancy. At the same time, you must keep in mind how these important decisions will affect you, your own health, and your family. Thank you.
Thank you, Rose, for such an informative session. We do have some questions posted by the attendees. I will start with the first question. Can I have a CAT scan during pregnancy, and how does this affect the fetus?
The radiation that is, again, of course, all these decisions are made in conjunction with your treating oncologist, but generally the information that we know is that the amount of radiation that is given off the CAT scan does not affect fertility, and it's used judiciously in pregnancy. It's a decision based on how important the scan is to the mother and the potential effect to the baby. So again, we know that CAT scans don't have an effect on fertility, but that's a decision that's made weighing the need for the mother to have the CAT scan and the potential effect that it could have on the fetus.
Okay. Question number 2. I have a 15-year-old son with SDH deficient GIST, diagnosed at age 12. He is not on any medication, and his GIST cancer is currently below the level of detection on scans. Can you recommend that he has his sperm saved in the near future prior to going on any medication, if, God forbid, tumors were to resurface?
Well, certainly at 12, when it seems right now that he's very stable and there's no indication that he's going to imminently need treatment, I think that you're safe to wait until the time may come, which again, like you say, hopefully not that he would need treatment. Because as I said in the presentation, completing sperm banking takes about 1 to 2 weeks. And generally, if there was some change in his status, you would have plenty of time at that point to consider sperm banking. So to answer your question now, I don't think it's appropriate or in any way needed. And if in the future it looked like he was going to go on medications and you had some concern based on what we, again, don't really know for sure are potential risks to his long-term fertility, you would have plenty of time in the future prior to starting treatment for him to bank sperm.
Okay. Question number 3. Do you know if most insurances cover any of the costs that you mentioned?
It's a very good question, and unfortunately my answer is that it is rarely covered. If you happen to have coverage for infertility, that is very different than what we're talking about, which is fertility preservation. So I always encourage everyone to check with their carrier, and when you go to see either a reproductive endocrinologist or at a sperm bank, you can ask specifically about your policy with their financial department. But generally, in most situations, there is no insurance coverage for fertility preservation in this setting. However, during our talk, I mentioned several resources that are available to patients who have a diagnosis of cancer, and they're available through the Livestrong Foundation for both sperm banking and egg freezing, and also Walgreens, in conjunction with a pharmaceutical company, has a program called Heartbeat, where they offer discounts for women who are freezing eggs. Now, these discounts are not financial. They actually supply, both Livestrong and the Heartbeat program, the medications that you would take. Remember, I mentioned the 10 days of injections. Those medications can run about $3,000 to $4,000. So if you're able to get the medications themselves through either Livestrong or Heartbeat, it's quite a good savings of $3,000 to $4,000. The other thing that I want to mention is certain reproductive endocrinology centers and certain sperm banks offer discounted rates to patients who have a diagnosis of cancer. irrespective of Livestrong or heartbeat. And you can ask that question when you're calling around to use a center, if they offer discounted rates for cancer patients. In that setting, they sometimes discount the consult fee, where the doctors accept whatever assignment insurance offers and don't charge any additional for the consult. Sometimes they offer discounted rates for storage. Storage for men, like I mentioned, can be $450 a year, and storage annually for women can be $950 a year. So sometimes certain centers will extend this courtesy to patients who have a diagnosis of cancer for the consult visit, sometimes for parts of the treatment itself, and sometimes for the storage fees. Finally, there are centers that offer discounted rates for long-term storage. If you have your sperm frozen or your eggs frozen at a certain center and you don't think you're going to be using them for a number of years, they can be transferred to long-term storage facilities that have a discounted rate. And then when you want to use them, they're transferred back. There is some fee for that transfer, so unless it's going to be a longer period of time, let's say for a very young patient who's not going to be ready to build their family for a number of years, it wouldn't be worth moving, but it's something to consider.
Thanks, Rose. I have one more question. Is there the ability to test sperm individually to detect whether or not the sperm is one that would pass on GIST genetically?
Great question. There's no way to test either sperm or eggs for the presence of any genetic mutations. What can be tested, however, is an embryo. Once an embryo is created, there is such a thing as pre-implantation genetic screening and pre-implantation genetic diagnosis. I was not sure about this question myself, and in my preparation for the talk, I spoke to the doctors here. And there is a very small subset of GIST tumors that can be detected through genetically through testing. You would have to speak to your doctor to see if your type qualifies for that. But if yours is potentially transmissible genetically, the screening that can be done is only done on embryos. So once a patient has created embryos with their partner, the embryo grows for a few days, they take a few cells, and they're able to detect any presence of that particular genetic mutation at that time. Again, it's a very small subset of GIST patients, and you would have to ask if yours was transferred genetically in that way.
Thank you very much, Rose, for sharing your knowledge with us today. This concludes our fertility webcast. Have a good day.
Thank you.